Hello everyone, we're doctors from the Department of Cardiovascular Medicine. In this series, we will walk you through ECG interpretations, step by step from basic concepts. The first episode here is ECG Basics. Let us begin with impulse conducting system. The heart's consistent contractions and expansions are controlled by electrical impulses and conducted by specialized cardiac muscle cells throughout the heart. This conducting system results in the blood to be efficiently pumped from the heart throughout into the body. The part where the heart's electrical conduction system starts is called the sinoatrial node or SA node. After the electrical signal leaves the SA node, it spreads out through the atria and causes contraction. The electrical impulse then triggers the atrioventricular node or AV node. As the electrical impulse travels to the bundle of His, which later bifurcates into left and right bundle branches, transmits the impulse to Purkinje fibers. The cycle begins again as the SA node initiates another impulse. Now that we have a general idea about the impulse conduction system, let's define some terms: P wave, QRS wave, and the T wave. The heartbeats are generated by repeating contractions and expansions of the atrium and ventricle. The P wave is formed when an electrical signal generated by sinoatrial node, SA node, is transmitted to the atria. At this point, the impulse arising from the SA node results in depolarization and contractions of the atria. After the electrical signal passes from the atria through to the AV node and His bundle, it is then transmitted to the ventricles. A QRS complex is formed when an electrical signal, the depolarization, is transmitted to the ventricles. It corresponds to the contraction of the ventricles. The T wave represents the period when the ventricles recover from the electrical impulse, the ventricular repolarization. As a rule of thumb, keep in mind that the P wave represents the atrial contraction, while the QRS wave represents the ventricular contraction. This animation here shows normal heart movements at the rate of 60 bpm. Next, let's talk about limb leads. 6 limb leads can be measured from the electrodes attached to the left and right limbs. The limb electrodes are colored in red on the right hand, yellow on the left hand, green on the left foot, and black on the right foot as presented. The right foot electrode, colored in black, is a neutral electrode, which serves only as a reference electrode for recording purposes. The relationship between the limb leads and electrode is described by Einthoven's triangle, which is the triangle formed by the 3 points of red, yellow, and green here. Lead 1 is the voltage between the positive left arm electrode and the right arm electrode. Lead 2 is the voltage between the positive left leg electrode to the right arm electrode, which is shown as the flow of electricity from the red dot to the green dot. Lead 3, which represents the flow of electricity from the yellow dot to the green dot, is the voltage between the positive left leg electrode to the left arm electrode. Starting from the center of the Einthoven's triangle, the electric flow directed towards the right arm, and left leg respectively are described as leads AVR, AVL, and AVF. Lateral leads 1 and AVL look at the electrical activity from the vantage point of the lateral wall of the left ventricle, whereas inferior 2, 3, and AVF view electrical activity from the vantage point of the inferior surface. We will now discuss the remaining 6 chest leads, precordial leads of the 12-lead ECG. From the right to the left, 6 electrodes are attached to the chest in the order of leads V1 to V6. Leads V1 and V2 are positioned in the fourth intercostal space, to the right and left edge to the sternum. Lead V3 is placed on the midpoint of V2 and V4. V4 is in the intersection of the fifth intercostal space and the left midclavicular line. Leads V5 and V6 are placed on the horizontal line at the height of V4 and the left anterior axillary line and the left mid-axillary line. Here is a cross-section view across the chest. V1 and V2 are septal leads for the observation of electrical activity from the vantage point of the septal surface and the right ventricle. Leads V3 and V4 are also known as anterior leads to look at the electrical activity from the vantage point of the anterior wall of left ventricles, septum, and the apex. Leads V5 and V6 are lateral leads used to look at electrical activity from the vantage point of the lateral wall of the left ventricle. In the conventional 12-lead ECG, which includes 6 limb leads and 6 chest leads, we are allowed to view the electrical activity of the heart from different directions. That being said, it is important to note that a 12-lead ECG does have its limitations, as not all abnormalities will appear on the result. For example, the electrical signals from the posterior wall, which is the back side of the left ventricle, may not be detected in an ECG examination. In the rest of this video, we will talk about how to read ECG paper. A standard ECG recording paper is a graph paper marked with a grid of large and small squares. One small square is 1 mm times 1 mm. For every 5 small squares, you can find a heavier line forming a 5 mm times 5 mm square. The horizontal axis measures time while the vertical axis measures the amplitude of the heart's electrical current. Each small square on the horizontal axis represents 0.04 seconds, while for every large square, it represents 0.2 seconds. By standard, 10 mm in the vertical axis equals 1 MV. Therefore, each 1 mm square vertically equals 0.1 MV, and each large square represents 0.5 MV. On standard paper with the most common tracing settings, 10 mm often represents 1 MV. However, please note that the paper speed or amplitude can be adjusted in some cases. This would mean a change in the height or width of the calibration mark. The heart rate can be determined by counting the interval between 2 successive QRS complexes. In general, the heart rate can be calculated by dividing the number of large batches between 2 successive QRS complexes into 300. The normal heart rate is between 50 and 100 beats per minute in adults, equals to 3 to 6 large squares between 2 successive QRS complexes. A recap of the 300 method. On a standard ECG paper where the 1 mm small square represents 0.04 seconds, the heart rate can be counted as 300 divided by the number of 5 mm large square between 2 QRS complexes. At the end of this video, we will talk about normal ranges of ECG patterns. The diagnosis of normal ECG is determined by components as follows. First, the P-wave QRS complex and T-wave are clearly identified on the ECG. Second, the P-wave is upward in lead 2. Third, the heart rate is between 50 to 100 beats per minute. In regards to T-wave, sometimes it is difficult to be identified. The normal range of PR interval measurement should be 0.12 to 0.2 seconds, or 3 to 5 small squares in duration. As for the duration of QRS complex, preferably less than 0.12 seconds, or less than 3 small squares. When the PR interval is increased to greater than 0.2 seconds, it implies a conduction block within the AV node or occasionally in the bundle of piece that impairs impulse conduction from the atria to the ventricles. Therefore, the conduction velocity is slowed. A QRS duration of greater than 0.12 seconds is considered abnormal, in which case the QRS duration lengthens when electrical activity takes a long time to travel throughout the ventricular myocardium. We will provide further insight into ECG interpretation in our coming videos.